Appreciate it. Let's see, does this little clicker work? Oh, perfect. Okay, good. Well, again, thanks for the introduction, Mr. Cobb. I'm Matt Logan. I've been in Greenwood my whole life. I grew up here. I have 3 kids in the district. I've got a 5th grader at Lakeview and a 8th grader at Westview and a 10th grader at Greenwood High School. I'm a Greenwood High School graduate myself, finished in 1993 and went away to school, went to Clemson and then medical school in Columbia and completed emergency medicine residency. I've been in the chief medical officer role for about 3 years itself. And unfortunately, the whole COVID pandemic kind of started during my tenure. So I was about a year into it when this big train kind of hit the country and in Greenwood certainly as well. So I want to just share with you a little bit, and if you can see the slides up there, what's going on in the state of South Carolina right now with COVID. These are the number of COVID-19 cases per day. You guys can see we had that initial little surge, like when everyone was all scared, like what is COVID? We don't have any PPE, no mask, those kind of things. We had that initial surge, we had that little lull. Then around Christmas time and on into January and February, we had this huge spike of COVID cases in the state. And then you can kind of see on that far right where we are now just over the last few weeks. At Self Regional, we went through about 3 weeks with 0 COVID patients in the hospital. During the middle of June. I was like, this is awesome. We're going to be able to go back to school. My kids are going to have like a normal school year again next year. This is going to be great. And then you start hearing some rumblings like, oh gosh, over in India, they've got this new variant, the Delta variant. Like, what is that about? And then you hear it kind of spreading through like the Middle East. Israel's got it. Then Europe's got it. Then you start hearing cases in the United States. And sure enough, it came and is here. And it's here in full force. You can see those cases there on the right side in South Carolina. DHEC has been doing some variant analysis, and like 90% of the cases in South Carolina are now the Delta variant. We have sent cases from Self Regional. We started sending all of any patient that was admitted to the hospital, we started sending them to actually MUSC to do some variant analysis, see what we're dealing with here in Greenwood. We sent our first batch about 2 weeks ago. 100% of them came back Delta variant in Greenwood of inpatients at Self Regional Hospital. Their MUSC is doing it about every 2 to 3 weeks. I think we're sending another batch later this week, so we'll see what our current inpatients look like. But just to give you an idea, it's without question we're seeing Delta variant here in Greenwood and our inpatients at the hospital. This is just a little comparison of a few other places around the country. That bottom slide is South Carolina, but you can see up above there Arkansas and Louisiana. And the number of cases they have, again, the Midwest and some other parts of the country are a little further ahead of us with this and seeing the Delta variant spike. And I don't know if you guys have watched the news, but if you'll just like Google on your phone and see what's been going on in Arkansas, Louisiana, and Florida, it's pretty concerning that we could be kind of heading that way. So I just share that as a little background of kind of where we are where we are now. So does the vaccine work? Let's just talk about that for just a little bit. This is a study pulled directly off the CDC site looking at vaccinated people from December through April of this year. VE just stands for vaccine effectiveness. And for those who are vaccinated, had basically a 91% effectiveness of the vaccine at preventing infection, and amongst fully vaccinated, 81% effective at preventing infection in partially vaccinated people. And when you compare those, like those that were vaccinated that ended up catching COVID, they had a 40% lower RNA load in their bloodstream than if they weren't vaccinated, had a shorter mean duration of detectable viral RNA. In other words, they weren't infectious as long if they did catch it, and had a lower risk of like the symptoms. And again, this is more recent, looking at July of this year, a look back of COVID vaccinated people versus not vaccinated, with an 8-fold reduction in disease incidence, a 25-fold reduction in hospitalization incidence, and a 25-fold reduction in death incidence in those vaccinated versus not vaccinated. And it's pretty powerful data showing kind of that the vaccines do work. And then where does the Delta variant fit with other infectious diseases that we know? So the SARS-CoV-2 Delta variant, if you see on the bottom part of this graph, let's say on the left side is like, you can think of it like less infective on the left side and more infective on the right side. So the original strain of SARS-CoV-2 was sitting there about a 1.5 or so, a 2 kind of an infectiousness level as compared to seasonal flu, common cold, very similar in infectiousness level to that. But the SARS-CoV-2 Delta variant is about 5 times more infectious than the original strain. So what does that mean? That means it requires less amount of exposure to virus particles to become infected. In other words, if it were to take like 100 viral particles to get into your system, now it only takes about 20 to get in your system to cause you to become infected yourself. So it's much more infectious. That's why we're seeing the spikes that we're seeing right now. And then I want to talk just a minute also about like the vaccine effectiveness. So you're seeing in the news, like Lindsey Graham is a great example, has been fully vaccinated and yet still caught COVID. Like, so why is that? Does that mean that the vaccines don't work? I think this is a good slide to kind of get to that a little bit. Let's look at the right side of the slide to start with. So Israel is a country that was vaccinated early. About 85% of the population in all of Israel has been fully vaccinated, okay? So if you look at the Alpha strain is the original version of the COVID before some of the mutations. And you can see, like, to prevent infection, you're up there in that 90+% at preventing infection. Same thing for symptomatic disease, hospitalization and death, and that 95 to 97% effectiveness at preventing that original strain. With the Delta variant in Israel, what they found is that those who are fully vaccinated are only about 64% effective at preventing infection and about 64% effective at preventing symptomatic disease. But still, that last one on the right side is just the key, still 93% effective at preventing hospitalization or death. So the vaccines still work very, very good at preventing hospitalization and death. So then, when I look at this, I ask the questions like, why are England and Scotland's Delta variant and Canada's maybe seems like it's working better in those countries? I think it has to do with like when they were vaccinated. So like Israel was vaccinated very early in the course of the pandemic versus England, Scotland, and Canada a little bit later on. And it gets to the point of where the Pfizer paper that came out about 2 weeks ago, where they start recommending the 3rd dose of the vaccine. So the booster shot, if you want to think about it that way. And plus the Delta variant wasn't around when the vaccine was first created, so it's not as powerful at preventing infection with the Delta variant as was with the original strain. So just a way to think about that. But you can still see, even with that said, still very effective at preventing hospitalization or death with the current vaccines. Again, Israel is almost 100% Pfizer vaccine. England, Scotland, Canada have a mixture of vaccines as well. Again, I just share this with you, not to get too technical on the biology of the virus, but I just want to just point this out, just to talk a little bit about, like, say, why is it important, or what is it that the vaccines are made out of, and what happens if you get infected versus if you get the vaccine as far as developing immunity. So if you look at this picture, what you see basically is a graphical version of what does the SARS-CoV-2 virus, this is the virus that causes COVID-19 infection, what does it look like? This is kind of graphical version of that. So on the inside you have that kind of red RNA. That's just like the genetic code inside of that capsule. So it's this sphere of capsule wrapped inside of that. It's that genetic material, that RNA from the virus. Then outside it's got these spike proteins. These spike proteins are what binds to your receptors in your body, in your airways, and in your mucous membranes if you get infected. Some specific receptors, the ACE2 receptors, but spike proteins grab hold of that. And when that happens, this literally what happens is it fuses with the wall of your cell and injects that RNA inside of your cell. Okay, you're getting that full viral RNA payload inside of your cell if you get infected with COVID. So what is the vaccine? How does that work? So this is just to show you. So if you take that RNA inside of that virus and you stretch it out like this big long string like this, and you look at it, it's got these different genes in it. It's got this ORF1A gene, the ORF1B gene, it's got this S gene sequence, and then a bunch of other little genes that code for different parts of the viral particle. So what the vaccine actually is, particularly mRNA vaccines, is with amazing technology. It's not me personally, but scientists were able to go in and splice out just that S gene sequence that codes for the spike protein on the outside of the cell. So when you get a vaccine, you get just that piece of RNA. If you get infected, you get the whole entire strand of RNA inside your cells. So, I mean, to me, it just makes logical sense. If I have to have a choice of getting that entire strand of foreign RNA in my system or just that one little tiny piece that goes for the spike protein, give me that little tiny piece all day, because you're only getting that little tiny piece instead of that whole string, but you're going to get it one way or the other if you get infected. And what happens is that little tiny piece of RNA is stabilized by super freezing it, and they mix it with some lipids and salts. That's all that's in the vaccine: lipids, salts, and that little piece of RNA. You get the injection, it gets taken up inside your cell, just like if you get infected with the virus, gets in the cytoplasm, that little string of RNA codes for the spike protein, gets out in your bloodstream, you make antibodies against it, and it gives you protection. If you get exposed to the virus in the future, you now have antibodies that can bind a hold of that spike protein on the outside of the virus and eliminate it. Does that make sense? I'm just trying to make it as simple as possible, but that's how the vaccines work. They're some of the cleanest vaccines. There's not preservatives or anything like that in these things. They're like way cleaner than a lot of the vaccines that we commonly give kids, MMR, goodness gracious. I'm going down the line of vaccines. So what's a variant? Like, how do we get variants? Where do they come from? The variants come from when you get infected with SARS-CoV-2 and it gets in your cells and it starts just replicating like crazy. Those who have a biology background know that you can sometimes get some errors in the replication process. There may be like an adenine substituted for a thymine or a cytosine for a guanine or something, and the code is a little bit different. And it can happen just from the random process of the replication. And it can change the shape of that S protein. The ultimate end product of the RNA is a protein, and it can change the shape of the spike protein on the outside of the virus, and it makes it where it grabs a hold to the ACE receptor tighter. And that's what's happened in the Delta variant. The Delta variant has basically a change in that S sequence of RNA, which makes it where the spike proteins bind tighter to the ACE receptors, and that's what causes it. So there's just a little bit of background. So again, just some vaccine safety stuff, common side effects. 75% of people will have low-grade fever, fatigue, pain at injection sites, very common. Anaphylaxis, very rare. Myocarditis, inflammation of the heart. Probably saw a lot of that in the news a while back. Again, pretty unusual. It does happen. Seems to be more common in younger folks, teenagers. However, I will say that even that, there's been some really good look-back studies on the teen groups that have developed this. Again, rare complication, but when they have had it, they all seem to be doing really well and get over it really quick. The average hospitalization for someone with myocarditis associated with the vaccine is about 2 days, and they seem to do really well with it without any long-term problems. The blood clots and Guillain-Barré syndrome that have been reported in some is primarily with the Johnson & Johnson vaccine. Does not use the mRNA technology. I typically don't recommend it because we have the other ones available. Johnson & Johnson's fine. If someone's had it, it's a great vaccine. But the mRNA vaccines just seem to be a little cleaner. The mRNA vaccines are the Moderna and the Pfizer. Another common question that we hear all the time is, what about pregnancy? I hear that there's a lot of stuff circulating on social media. It may not be safe in pregnancy. Good study published in New England Journal of Medicine in April of this year, where they did a look back of 3,958 patients that received vaccine in different stages of pregnancy. You can see there was a small number prior to pregnancy. About a third in their first trimester were vaccinated, 1,700 in the second trimester, and about 1,000 in the third trimester. And what they found was that when they did this look back, there was no difference in outcomes so far as miscarriage, preterm birth, small size for gestational age, birth defects, or neonatal death, and those that were vaccinated versus the baseline rate that you commonly see in the population. Yeah, there were some people that had miscarriage or preterm birth that were vaccinated, but when you compare that on a population level compared to baseline rates, there was no significant difference between the two. This was followed up with another study in June, also published in the New England Journal of Medicine, basically reinforced this. The American College of Obstetrics and Gynecology 2 weekends ago released their statement that they recommend that everyone who's pregnant or trying to get pregnant does go ahead and get vaccinated for COVID-19. They feel it is safe and effective. Another common question, if this helps anyone in the district who's thinking about, gosh, I'm a young female, I'd like to get pregnant one day, and I hear that it can cause fertility problems, and I'd just be concerned about that. Well, I can tell you, as of June the 12th of this year, more than 2.3 billion COVID vaccines have been administered across the world. There has not been a concomitant reduction in fertility or difficulty getting pregnant across the world in that same time frame. The American Society of Reproductive Medicine, this is the group of physicians that represents a professional society that represents reproductive endocrinologists. So, for example, if you're trying to have a baby and you're having difficulty getting pregnant and you're going to the specialists that deal with fertility problems. So to me, this is a really powerful statement. They recommend that patients undergoing fertility treatments and pregnant patients should be encouraged to receive the COVID-19 vaccines. So if you think about it from that perspective, my goodness, you've got like the most difficult people to get pregnant, and they're saying, go get the vaccine. You can't imagine that a professional society like this in this country would be derelict in their duty in making a recommendation such as that. So I just pass that along to the group. You guys may have seen this. I don't do this to be dramatic, just to share a real-world example. If you guys are familiar with Chris Justus on the news and what happened to his family recently, his sister-in-law, his brother's wife, was pregnant, 30 weeks pregnant, and he posted this, I guess about a week and a half ago now. And she contracted COVID, ended up in the intensive care unit, ended up having to have an emergency C-section because she was declining. And the baby survived, went to the NICU, but unfortunately she died at age 31 years old of COVID. Mm. And you look at a picture like this, and it's like, my God, this looks like some of our friends that live on my street over in Hunters Creek, that it just kind of hits home. I mean, this is real. We see it in the hospital every day. Our numbers are increasing in the hospital. Just to give you guys a reference, I mentioned we had 0 COVID patients in the hospital back in June. As of this morning, we have 27 in the hospital. We have 8 of those patients are in our intensive care unit. Of those 8 patients in our ICU, 7 of those are not vaccinated. 1 is vaccinated. We have 3 patients on the ventilator as of this morning, all 3 not vaccinated. We have, again, of the 27 patients in the hospital total, again, as of this morning, 20 of those not vaccinated. So, like I say, it doesn't mean that you're not going to get potentially sick if you are vaccinated, but your chances of ending up in the ICU and ending up like in the morgue are much lower if you are vaccinated. So I would encourage all of your staff, all of your students that are eligible to get vaccinated. In regards to, I know our governor has put a lot of limitations on what the district can do to try to help keep our kids safe. The masks do help. I mean, it's unfortunate it's kind of become a political ball, but they do help prevent infection from spreading from one to the other. Whenever it's allowed, if the governor is able to open it up a little bit, allow some mitigation efforts. Another thought I was just talking to David Trent here about a little while ago is, the plexiglass, if that could be considered, or something to try to help spread the students out more. Put the plexiglass back up. Do some things that we are allowed to do to try to help protect our kids. We are seeing a shift in the age of the people who are contracting COVID to younger age group. So in the first couple surges I showed at the beginning of the talk, the population age was like around 68 to 70 years old were the most of the people that were having bad outcomes, and we're now seeing that shift more to like those in their 50s. Here locally, and it's not just here, it's throughout. So I would encourage the district to consider doing whatever they can do within their limits to try to protect the kids in the school district. And I hope I touched on what Steve wanted me to talk about today. I'm certainly open to any questions that any of you guys may have.
Any questions for Dr. Logan?
Dr. Logan, this was very informative. I mean, as a parent, and you worry about the safety of having your child vaccinated. I talked to my doctor. She absolutely, I have a 15-year-old, and so she's been vaccinated, and if it's good enough for my doctor's child, in my book, it's good enough for me.
Well,
so,
I'll speak to my own. My 15-year-old and 13-year-old have been vaccinated, and my 10-year-old, if I could give it to her, I'd give it to her this afternoon. But it's not eligible. She's not eligible yet. And my parents, my in-laws, my wife, I really feel it's safe and effective, and give it to my own kids as well.
And that's a family's choice. They need to decide what's best for them. But this
That's
information helps people make those decisions. And when you're open to hearing facts from somebody as informed as you are, that helps.
Thank you. Any other questions?
Dr. Logan, what is the data telling us right now, as far as you said that the Delta strain is starting to get younger as far as the patients are concerned? So as a school board, I feel like the most informed decisions we can make are on the data. where are we as far as elementary kids versus middle school age versus high school age?
You know, the schools are just starting back, so it's going to be hard to know. You give it about 2 or 3 more weeks across the state of South Carolina, and I think we'll have a really good feel for how that's going to play out. I think one of the reasons why we're seeing more younger people get COVID is, well, basically in the state of South Carolina, like 84, don't quote me exactly, but it's around 84% of those over 65 years old have been vaccinated. So that very vulnerable older population has already had the vaccine. It's the younger people who haven't been vaccinated that are ending up in the hospital. So it could have a function of not that it's affecting the kids as much as that the data is skewed because the older people have been vaccinated. It's really more of a vaccinated versus unvaccinated, perhaps, rather than just pure age, if that makes sense. But again, I don't think we'll know specifically in the kids until we get a little further along. I can tell you, if you Google like Arkansas pediatric intensive care units, their peds ICUs all got filled up with kids over the last month or so with their COVID surge. So again, kind of a cautionary tale. It'd be awesome to be able to do a little more mitigation in the school-age kids. I don't think we'll know here for sure for a little while. Elizabeth Mack is the medical director of the Pediatric ICU down at MUSC, and I know on a conference call last week, or maybe it was 2 weeks ago, she was expressing they're starting to see more and more in their peds ICU. Again, anecdotal things, but it is a little worrisome.
Yeah, and that's. But to your point, I mean, that's sort of a scary situation with a pediatric patient that needs oxygen or needs to be on a ventilator. Is we really don't have as many beds available just because you have to have a pediatric ICU where these kids, maybe MUSC or whatnot, is that where they'd have to go if they needed that intensive?
So our closest pediatric ICU is in Greenville.
Okay.
This is there's one in Augusta, and then certainly in Columbia and in Charleston. We send most of our pediatric ICU stuff to Greenville. I can tell you last week the peds ICU in Greenville was full. Not all COVID, but they had it's been a really hard RSV season the last couple of weeks, month or so, and so they have a bunch of respiratory sick kids. We had a RSV child with a child with RSV itself that we were trying to transfer up there that needed that level of care, and they didn't have any beds there. Yeah. So that is a little worrisome if kind of that's where we are as a starting point. Again, I'm not trying to scare people. Just that's just kind of what the reality is right now.
Yeah. Makes sense. Thank you.
Sure.
There was a large boost. You specifically mentioned Louisiana and Florida, and those probably came about 3 weeks ago was when we really started to see that. And there is no wavering as far as their numbers are concerned. They're still operating at a high level of infections. Or has anything come down?
Yeah, so those that are a little ahead of us, so the Delta variant is you can kind of think of it like a fire that's burning really fast as opposed to one that's burning really slow. So what we've seen in some other countries as well as here in the United States is that it's peaking like quicker, so the rate of infection is much higher and it comes down quicker. Again, we don't know for sure how it'll play out for sure. Like I showed on those first graphs, it's still kind of on an uptick. I pulled these. Let me just pull it. So these were pulled, I think last week. It may be on there, but anyway, about a week or so ago. And you can see they're still pretty much on an uptick. So I don't know where it'll end up settling out. Hopefully it'll plateau and come back down as fast as it's risen. But if you look at that curve, it's steeper than the previous surges were. So hopefully it'll come up and back down. So I was reading an article, I'm sorry I can't quote where I came from over the weekend, but it was saying that most likely in the United States, hopefully by third week of September, we'll be kind of on the down of the Delta variant. But it's really, we just don't know for sure yet.
You touched on the booster. Who needs to get a booster and what kind of time frame? You know, a good many of our teachers were vaccinated, or staff people were vaccinated at one time. Are they eligible for a booster? Do they need to be looking at that?
No, it's a good question. And so the FDA approved on this past Friday, a booster shot for folks who are immunocompromised. And they recommended that you don't have to get a doctor's order for it. So if someone's immunocompromised, whether they're on chronic steroid therapy or they've had a kidney transplant or whatnot, that they are eligible to go ahead and receive a booster, third dose booster shot. And so, we offered it self-regionally. You can come through our drive-through line and just basically sign a form saying that I have a immune system problem and need a third dose, and they'll give it to you. That's all you got to do. And you can talk to your doctor about it if you're not sure if if you qualify
For
or
the
not.
general public, people.
Yeah, otherwise healthy people, it's not recommended yet.
And you still have to have the same vaccine. If you had Pfizer, you need to still get Pfizer. If you had Moderna, you need to get Moderna.
That's a recommendation right now, unless if you between a conversation between you and your physician, you feel like perhaps a different option should be done. Particularly if you had Johnson & Johnson, there's some recommending that since it is only a 1-dose vaccine instead of a 2, that either getting the Pfizer or Moderna may give you an extra boost. So it's, again, a discussion between you and your doctor. And if you wanted to get one, like a second dose of one of those in that situation, it honestly would probably be reasonable. But again, I just talked to your doctor about it, but we can help you with that at the hospital.
Well, this is my last question, but maybe it'll help some folks out there. It sounds more selfish question, but maybe it'll help someone in my situation. So I got my first dose in December, and I read that the Pfizer vaccine, the efficacy drops off at a decent amount after 6 months. So they're looking at this right now for even just folks that aren't immunocompromised, that possibly a booster would be coming soon.
Yeah, I refer you back to this slide and looking at Israel and about how, again, they're about 6 months out since they mass vaccinated their population. You can see the vaccine effectiveness was about 64% as compared in the 90s originally. So the Pfizer data that was released about 2 weeks ago, they looked at 6 months out, and they wanted to get approval to go ahead and do a booster across the country, but the FDA felt like there wasn't enough evidence yet to support that. So for otherwise healthy people, you can still see very effective 6 months or so approximately out, 93% effective at preventing hospitalization or death. If you do contract it, most people who are otherwise healthy will probably just kind of feel crummy and should self-isolate. Go get tested if you have cold symptoms. And if you test positive, you should be out for 10 days and, again, 24 hours past the last time you feel sick before you're kind of around people again. But it's a good question. I suspect it'll probably come. And, we may be dealing with this for a while. This is the Delta variant. Who knows? Again, if everyone was vaccinated across the world, we wouldn't have enough hosts for the variants to form. But the reality is it probably will not get there. We probably will have some others. The fear is that, as more of these things replicate, could we have a variant that does affect kids preferentially to adults? So, their little receptors are a little bit different than ours. And I think that's probably why they aren't as infectious as others or get infected as often as others. But it would be really bad if that kind of happened and it became where it does affect kids more than adults and whatnot. So, again, the more people that are vaccinated, the less opportunity there is to create one of those bad variants.
I know right now that, the limit's 12 years old. Are they considering dropping that limit on down? Or?
Yeah, there's active research going on right now with that. It'll probably be December or January before that's opened up to the younger age groups. Unfortunately, I wish it was going to happen sooner, but it'll probably take that long before that data's out and available to make a decision on by the FDA. Good question.
Any other questions for Dr. Logan? We certainly appreciate you being here tonight.
Sure.
It was so informative. I know that, and we appreciate Self and you working behind the scenes with the district as you have since this
Sure.
started.
Well,
Very
glad to help,
grateful.
and I'll say Steve has been awesome to work with, and thanks for letting us come to the schools and do some vaccinations there. And whatever we can do to help, just let us know, okay? Thank you, guys.
Thank you.
Appreciate it.